Bismillah ar-Rahman ar-Rahim. Thanks for the chair board and thanks for the invitation, Professor Mohamed Subhi and Professor Mohamed Ayman. In the next few minutes, I will highlight one of the most important topics nowadays in echocardiography, which is echocardiographic diagnosis of heart failure with preserved ejection fraction. Rationale for role of echo in heart failure: bedside non-invasive imaging tool, low cost and no radiation exposure. Goals of echocardiography in heart failure patient in general: to highlight the underlying cardiac disease, to quantify systolic diastolic dysfunction and the hemodynamics, to match symptoms and the cardiac involvement, to stratify prognosis, and to guide the therapy. Potential benefits: the importance of being diagnosed earlier. The overview for this context: non-invasive imaging, particularly echo, plays a central role in evaluation of HFpEF. Echo helps to rule in HFpEF among patients with unexplained dyspnea when the diagnosis is uncertain, because it is not a straightforward or easy job like HFrEF. In established HFpEF, echo provides important insights into the pathophysiology and phenotyping, such as isolated RLV diastolic dysfunction, left atrial dysfunction, abnormal left atrial pulmonary artery coupling, ischemia, or obesity phenotypes. Imaging enables the risk stratification for HFpEF. Establishing the diagnosis of heart failure: some important checklist questions, including: is left ventricular ejection fraction preserved or reduced? Is the left ventricular structure normal or abnormal? And other associated structural abnormalities. The survival for heart failure patients is better for echo-diagnosed patients when compared to non-echo-diagnosed cases. Here, an important position paper about the role of echocardiography in heart failure with preserved ejection fraction, and the title of my presentation: what do we want to know from imaging? Two important scores for the diagnosis of HFpEF. One is very practical and depends on simply applied parameters, which is called HFpEF score, depending on the body weight: heavy, hypertensive, H2, and atrial fibrillation takes score 3, and pulmonary hypertension score 1, elderly, age more than 60, score 1, and finally filling pressure diagnosed in terms of elevated E/E' more than 9 by conventional and echo Doppler. The odds of HFpEF doubled for each 1 unit score increase. The H2FpEF score was superior to the currently used algorithm based on the expert consensus. The validity of H2FpEF score, although it depends on very simple parameters, H2FpEF score relies on simple clinical characteristics, and echo enables the discrimination of HFpEF from non-cardiac causes of dyspnea and can assist in determination for the need for further diagnostic testing in the evaluation of patients with unexplained exertional dyspnea. Recently, the European Society of Cardiology proposed another important score, which is HFpEF score, handling major and minor criteria like rheumatic fever and infective endocarditis. Depending on echocardiographic parameters like septal and lateral E' and average of E/E' more than 15, which are major criteria: left atrial volume index, left ventricular volume index, and N-terminal pro-BNP and BNP. And lower values of these parameters is considered as minor criteria. Each major criterion takes 2 points, and each minor criterion takes 1 point. The diagnosis of HFpEF is confirmed when you have a score equal or more than 5. Intermediate cases or borderline cases having a score between 2 and 4, in this situation, you will be in a need for doing a confirmatory test or non-invasive hemodynamic test. Back again to the question of my presentation: evaluation of HFpEF. What do we want to know from echocardiography? When elevated over E/E' and right ventricular systolic pressure may serve the best echocardiographic parameters to identify HFpEF. Other indices may provide ancillary information, including transmitral flow pattern, left atrial volume index, pulmonary venous flow, left ventricular mass index. Imaging provides insights into the pathophysiologic mechanisms that may guide phenotyping in the individual HFpEF patients. Risk stratification is also feasible with echocardiographic application, including left ventricular hypertrophy for increasing left ventricular mass index, impaired LV systolic performance, and for the first time to have the global longitudinal strain in the guideline recommendation for diagnosis of HFpEF, and it is considered as one of the minor criteria. High filling pressure, left atrial dysfunction, pulmonary hypertension, RV dysfunction expressed in decreased TAP C fractional area change, right ventricular ejection fraction, and the TAP C RV systolic pressure. In intermediate cases, we will be in a need for diastolic stress test and measuring the pulmonary artery pressure at rest and during stress. And also, new echo parameters enables the evaluation of right ventricular function expressed in annular plane systolic excursion of the tricuspid valve, RV function, and right ventricular area change, and the tissue Doppler velocity of the right ventricular free wall. Here an example of provocative of exercise stress test for increase of E over E dash having a borderline value of resting value of 10, and by bicycle ergometry it is increased up to 18 during stress. Another important parameter is expressed in this shape, what's called the D-shaped ventricle. The interventricular septum is flattened due to pressure overload of the right ventricle, giving the appearance of the D-shaped ventricle as we see. Another parameter is prominent epicardial fat in obese patient with HFpEF as we see. A very important and simple, highly reproducible echocardiographic parameter is E over E dash, which is highly correlated with the left ventricular filling pressure, left ventricular stiffness, and it is highly, extremely strongly correlated with the N-terminal pro-BNP and BNP, as we see. This one of our favorite publication in our Echo Lab, which address the relation between left ventricular function expressed by mitral annular plane systolic excursion and E over E dash. As we see from your right-hand side, there is a great correlation between BNP and E over E dash. So if you measure E over E dash accurately, you will have a very good idea about the BNP and pro-BNP in your patients. Left atrial volume index is another important parameter in HFpEF diagnosis, and in the new score, HFpEF score, if it is more than 34 milliliter, it will be a major criteria, takes a score of 2. Another important parameter is left atrial volume index over the A dash, which is helpful in the diagnosis of HFpEF. Finally, to summarize, if you have a rapid checklist for diagnosis of HFpEF variables, left ventricular diastolic dysfunction expressed by transmitral conventional Doppler or tissue Doppler, left ventricular systolic dysfunction, which is subtle, and this is the rationale for the change of the term diastolic heart failure into heart failure with preserved ejection fraction, because diastolic heart failure is not clear or accurate terminology, because all causes of diastolic heart failure in the older terminology may have subtle LV systolic dysfunction. So the proper terminology is heart failure with preserved ejection fraction, because it may have some hidden or subtle LV systolic dysfunction. Pulmonary hypertension, RV diastolic remodeling, left atrial dysfunction, enhanced diastolic ventricular interaction, or what is called D-shaped ventricle, vascular stiffening, microvascular dysfunction, peripheral abnormalities, and chronotropic incompetence. Finally, in conclusion, my take-home message, HFpEF is a clinical syndrome that is increasing in prevalence, coupled with growing population burden of aging and comorbidities. Cardiovascular imaging plays a key role, note, in the evaluation of management of HFpEF, particularly echo. Echo provides essential information on the cardiac structure, function, hemodynamics, and it is performed essentially in all patients where there is clinical suspicion of HFpEF. From practical standpoint, the most important questions are: diagnosis determining whether a patient with unexplained dyspnea truly has HFpEF, or an alternative diagnosis, cardiac or non-cardiac causes of dyspnea. Management, where imaging can be used to evaluate hemodynamic status, determine the underlying pathophysiological phenotypes. Lastly, risk stratification for outcomes and prognosis. And this is my last slide. And finally, thank you.